Hello, I'm Dr. David Hornbrook, the Clinical Director of Education and Technology here at Keating Dental Arts in Irvine, California. Today I want to talk about a product that I think is revolutionary. You know, one of the hot buzzwords in dentistry right now is bioactive. Is this restorative material bioactive? Is this cement bioactive? And what bioactive means basically is that it's a substance that interacts with living tissue. You know, I like to classify bioactive as regenerative restorative materials, where there's an interaction that'll actually regenerate or form healthy tooth structure when it's associated next to these bioactive or regenerative materials. Now, if we think about when we would use these type of materials, you know, bioactive is not new in dentistry. We've actually been using it for over 25 years. Some of the coatings that they used to put on implants to help with osseointegration. We would actually see some of the apatite interact with these coatings of implants, ideally to help them to integrate more efficiently. Now, the product I want to talk about today is called TheraKalel LC from Bisco Dental Products. And I like to say it's a calcium hydroxide on steroids. Because we do have situations where we either have a direct pulp exposure or we have very, very deep dentin where we're concerned about sensitivity and we want some remineralization in that deep dentin. Traditionally, we use calcium hydroxide. The advantage of calcium hydroxide is it was easy to place. It had been used in dentistry for many years, so at least we had some clinical experience. And it did kill bacteria because it had a very alkaline or basic pH, so it killed bacteria. The problem with TheraKalel is it didn't bond to the tooth. It didn't bond to the overlying restorative material. It was very water soluble, and it had very poor compressive strength. And we've all taken out existing restorations, usually amalgams, and there's either a void underneath the amalgam or it looks like cottage cheese underneath the amalgam because either we or another dentist in the past, when they had a deep cavity preparation, they placed TheraKalel, and then with the leakage of the amalgam, it kind of just washed the TheraKalel out. So TheraKalel is an option, not a great option in my opinion. The next is glass ionomer, and we were excited about glass ionomer when they first came out because we had fluoride releasing properties. Now the advantage of glass ionomer over TheraKalel was it actually was a little bit more durable once it's set up. Also, it did bond to tooth structure a little bit. The problem is that glass ionomer is cytotoxic and you don't want to put that on a direct pulp exposure. We could put it in deep dentin, but again, we don't have really high bonds and we don't have high compressive strength. The third material, which it really has great studies, is MTA. MTA is mineral trioxide aggregate. And endodontists really started to use that when they had perforations in roots or when they're trying to get apexification. There's great data that we actually do get interaction and new apatite formation when this material is in close proximity or interacts with dentin. The problem with MTA, it has about a 3-hour set time. That's not a problem for an endodontist. He puts it down a canal and seals it. Certainly a problem for me as a restorative dentist. I'm not going to sit around and wait 3 hours for this to set up before I can place my restorative, so that's not a good option for me. Recently, and this is where TheraKalel LC comes into play, manufacturers have created what we call resin-modified calcium silicate cements. And that's what TheraKalel is. And what this is, it's actually a resin-based material that has chemistry similar to MTA, and it is bioactive. So we actually get an interaction between the tooth, we get new apatite formation when it's associated next to this TheraKalel LC, this regenerative material. Now, where we use TheraKalel LC is direct pulp caps. Awesome for that. Once we control the bleeding, assuming that it's not necrotic, we go ahead and put a very thin layer of TheraKalel. Typically, we like to keep our increments to 1 millimeter or less in thickness. It has a photo initiator in it, so we actually light cure that and it sets hard. So then we can move right on to our restorative. Now, what's different between TheraKalel and some of the early silicate cements is TheraKalel actually has a hydrophilic monomer that allows interaction with the calcium hydroxide and the calcium in the tooth and the TheraKalel. So we do get ionic exchange. Some of the early cements, they were so hydrophobic that water could not allow that ionic exchange. So they weren't really regenerative or bioactive. So I'll use TheraKalel LC direct pulp caps. And then after I place it in light cured, I can go right to a total etch or select etch, whatever you like to use with your restorative. And I'll also use it in areas where I have very, very, very deep dentin exposure, maybe not a pulp cap, but I'm worried about thermal sensitivity or post-operative sensitivity by having that restoration so close to the pulp. I'll put a very thin layer of TheraKalel, sets up very quickly, 10 to 15 seconds, and then I can move on with my restorative. So hopefully you'll get a chance to look at TheraKalel LC. Again, these bioactive materials, or regenerative materials, are going to change the way we do dentistry in the future. Imagine if we could have a cement for our crowns or a restorative material that actually interacted and remineralized the tooth as that microscopic roughness between the restoration and the tooth. As that demineralized, we'd have this interaction. These restorations could actually repair themselves.